Pleasure to introduce the next speaker, who does not need any introduction actually in this audience. He is my overseas trainer and mentor and now good friend of mine. Mr. Janindra Warusawithana is a consultant colorectal surgeon at St. Mark's Hospital, London, which is the mecca for colorectal surgery. Although this year also he couldn't be with us. I think he has taken time off from his early morning jogging routine to give us a talk on achieving remission in IBD, biologics or surgery, a surgeon's perspective. Over to you, Janindra.
Thank you, Sanjeev. Can you hear me?
Sorry. Yes, we can hear you clearly. Yeah.
I'm a little bit off a jogging routine for reasons I think you've sort of worked out, but I'm struggling to actually see the screen so I can actually show you what I'm seeing. Sorry, give me 1 second. Can you see me better now?
Yes, we can see you better. Yeah.
Can you see the screen now?
Yes, we can see the screen. Yeah.
Awesome. Sorry about that. Right. So thank you for this, and I'll join you guys a little bit later again as well. We're talking about achieving a remission in IBD, whether you use biologics and surgery. And actually, that's a really good topic. Not only is it a good topic, I think it's a really good discussion as well, because things are changing and there is a massive paradigm shift in how we actually look at things here. And when we actually think about it, you know, the reality of how we deal with any of these situations is, are we going to move to reduce recurrence? How are we going to look at the role of medications in these conditions? And what are the surgical complications, if you like, in these situations as well? And the important thing to remember here is that the way we look at things is slightly different. I'm sorry this thing is moving. I did it as a video recording and now it's completely stuffed up, so I'm going to just talk through it. Anyway, in the early days, surgery for Crohn's was the way things happened. You had a problem, you had surgery. But then people started to change massively because the reason was that the recurrence rates were incredibly high with surgery. And one of the big issues in that circumstance was that, especially in the 1950s and 60s, you would start to see that over a period of up to about 25 years, about 50% or more people actually ended up having another operation. And in those days, that wasn't necessarily a good thing. And if you look here, you can see that as you started to develop biologics, your need for surgery in the longer run started to drop. So by the time you got to the 2013s, your need for short-term surgery, or at least the number we always use is about 20% will need a second operation. That's much less than 50%. So the pendulum swings. The pendulum swings that it becomes more appropriate to have medical treatment rather than surgery. And then medical treatment, for obvious reasons, and you can see from the previous speaker as well, there are certain things that make it slightly different in how we actually approach those medical treatments. You start off with things in a slow way, and then you gradually build it up to the more expensive treatments, and then finally you come to surgery. Now that you may say, well, what's wrong with that? What's the problem? And realistically, there is a problem, and we'll talk about it. But it seems like a very step-by-step approach, and therefore things look okay. But let's ask ourselves a question: did the biologics really reduce the need for surgery? I think it probably prolonged the time interval for surgery, because 70 to 90% of patients with ileocolic Crohn's disease will still need a resection somewhere in the next 15 years. And 20% or so will still need surgery within a year of diagnosis. The problem for us as surgeons is, do we actually have to operate on those sicker patients? And are we actually doing things differently to the point where we may be having to give more stomas for argument's sake. These are unpublished data, which is a little bit old from the UK. But what you start to see is that as the longer you go, the more problems you have with, for example, open abscesses or needing laparotomies rather than actually laparoscopic surgery. But actually, the concept of early surgery doesn't exist in a lot of major centers because our way of dealing with the situation is still to use a lot of biologic treatments. But there is a little catch in that, and you have to be very careful about this because as you start to swing along, and they start to get problems with their ileum, and we'll concentrate on terminal ileum because it's an easy one to sort of understand the concept a lot. You can start to see that weight loss becomes an issue, having inflammatory masses, being able to do a resection without an anastomosis, and so on and so forth, all becomes a bit of a problem. And then the next thing, and this is going to be the next big study that will come through the UK in terms of how we actually look after some of these patients, is the concept of malnutrition. And we haven't really progressed getting people's rates of malnutrition or getting their nutrition in a better way before surgery. And that this is where things are going to move. But the important thing to realize is that at least about 50% of your patients that you're going to operate on are going to have serious malnutrition. And we're talking about weight loss of more than 5%. And you might think, well, what's a big deal about 5%? But for an inflammatory patient in Crohn's disease, a weight loss of 5% is big. And it is also associated with significant postoperative complications. So what do we as surgeons like to avoid? Well, we want to avoid all of these situations. You want to avoid abscesses that are not resolving after drainage. You want to avoid intracutaneous fistulas. You'd like not to have multiple fibrotic strictures, especially given that medication, at the moment at least, doesn't really help fibrosis. Maybe later they will. So when you start to think about things, you've got to think, well, where are we going to draw the line? If surgery is inevitable, why don't we do it first? We can reduce the risk of complications. We can have, even though the top-down approach may be beneficial in some of these patients, we don't really know who they benefit much. And certainly, it's not the real practice or the best practice, as was discussed in the previous talk as well, because there's a cost associated with it. So it's not that every single one of your patients is going to get a biologic drug. That's certainly not going to happen in the UK or anywhere unless they're going to pay it for themselves. And then remember that every time you give these drugs or you change drugs or you go through that top-up approach, you're going to develop areas of fibrosis, and they're going to be multiple as well. And that's going to be another issue that eventually means that the way you deal with the surgery is very different to the way you deal with it if it is dealt with better early. So I'm going to go back a little bit to how people looked at early versus late surgery. So in this study, you can see that early surgery group, they had a little bit less clinical recurrence. Their surgical recurrence was not that different, and they had longer clinical remission. And you can see that as sort of time goes on, you know, there is really not a huge difference in terms of having, you know, diagnosis at surgery is not the only independent predictor of reduced further surgery, right? And the natural history, if you like, of the Crohn's diagnosed as surgery, if so, for example, if you have a patient who has a right iliac fossa pain and you do a laparoscopy, there is a reduced risk of reoperation and there's a longer time interval between diagnosis and need for further surgery. But if you then ask gastroenterologists, what do you do for a patient who's got diagnosis of terminal ileal Crohn's disease, and remember this is 2008, at emergency laparoscopy, about half or more would say do surgery. About 40% of surgeons would say do nothing. about a third would do a limited ileocecal resection, and a third would remove an appendix. I'm not really sure what the appendix is going to do by removing it, but nonetheless, there you go. But in the elective setting, very, very few people would even offer surgery. And that, for the reason for that is, I think, also laparotomy, the way things happen, the complications afterwards, and so on and so forth. But don't forget that things like everything has changed. The drugs change, the surgery change as well. We're doing laparoscopic surgery, we can do single port surgery. All of those have less pain, shorter hospital stay, but also it's better cosmetic results for the patient. So they're not starting to feel those horrible incisions. And one of the other things, and the reason for this I don't really know, is that there is a significant reduction in surgical recurrence when you perform laparoscopic surgery. And what we don't talk about is actually drugs have their complications as well. Everybody talks about the stuff-ups you can do with surgery, but very few people really talk about some of the massive issues you can get with medical treatments as well, and we need to be aware of that. Now, let's ask the next question. If you actually give people biologic, do we change the way things do? All we do is increase the time before patients have surgery, but we're not reducing the length of ileum that we're actually removing or anything else. And this is where probably one of the best trials for this time being at least came out, which is the LYRIC trial. And the LYRIC trial basically looks at whether there is a difference between doing surgery in patients who are capable of having surgery versus having infliximab as treatment. So it was a randomized controlled trial, and it had the first-year follow-up and then subsequent 5-year follow-up as well. And the most important thing to realize is that about 26% of patients who had a laparoscopic ileocecal resection as the first-line treatment needed infliximab, but no re-resection after 5 years. But in the infliximab group, half of those patients actually needed a resection, and the rest continued with some form of drug. So if you look at the origin, the start part of the trial, we had 65 infliximab and 70 for surgery, and we looked at quality of life, and there was no difference in quality of life between surgery or medicine, although in SF36, surgery group was a little bit better. That's because you get your results very quickly. 30% had to stop infliximab and went on to surgery even after a year, but only 4% after a year at surgery started infliximab. And you can see the complication rates weren't massively different between the two groups, and the quality of life in pure looking at the first line principle was much the same. But and there are multiple other studies that have come through the LYRIC about cost effectiveness as well as things. But where we go back to it is that if maybe SF36 and EQ5D make surgery look a little bit better, and it's certainly much, much cheaper to do an operation than continue with medication. And so if it's available and if it's done well, I wouldn't say it's necessarily a bad thing. But here is the most important thing that I think comes out of the LYRIC trial. If you have the anti-TNF group, about half of those patients, even after 5 years, will need a resection. About 38% will continue anti-TNF, or another 14% or so will continue biologic or an immunomodulator, with an immunomodulator. But in the surgery group, you've got 42%, half of those patients, or nearly, who had no medication at all. That's it, game over, at least for 5 years. And that's not a bad thing when you think about it. About 31% will only need an immunomodulator, and 26% will need a biologic treatment. And that's not a bad thing either. But you've got to start thinking about how are you going to choose these patients, and that's the next step, and that's actually quite a harder step to do. But we know certain things. For example, smokers, definitely their postoperative recurrence is high, so stopping smoking is really good, or having a different approach to those patients is really good. there is the whole idea of medical treatment in the right patients as well. And I'm not going to dwell on this too much, but maybe perhaps look through the POCA care, where if you POCA study, sorry, which is a very good study about looking at active care, which is to look at the anastomosis at regular intervals and then starting the treatment at the right time will also reduce your risk of remission. So it's not just about saying doing surgery stops you from needing everything. It's about saying, let's now look at our patients properly and have a very guideline-based approach on how we deal with the situations. And you can see here from some of these studies looking at the AMC and Leuven and as well as the Lyric, that actually your surgical recurrence rate is quite low in the laparoscopic surgery. The problem happens when you start to say, okay, here's the approach, let's just go for it. And this we saw with the Lyric trial. Trying to get patients recruited was actually quite hard because patients sometimes make their own decision making. And I think we as clinicians are responsible for that, because you'll get a gastroenterologist who says one thing, a surgeon who says the other thing. Half the time we don't talk to each other, and then we try and give our own information to the patient, and they have no idea how to make the decision. So then they go social media or do something like that and come up with their own decisions. And this is where the value of the multidisciplinary team comes into being. If you actually sit down together and talk about things and say, here is a patient that will actually probably benefit from surgery. Here is a patient that will benefit from medical treatment. You can then go together into a joint clinic and say, here is what we think, and these are the reasons we think. The patients really like that because they can see that their gastroenterologists and surgeons are actually talking together. But they also have their own approaches using social media. They'll get another second opinion from someone else, or they'll choose specific doctors. They have a balanced view, and so on and so forth. And it's important to actually bring that into being. And then maybe you can have a medical therapy versus surgical therapy algorithm. You know that if you have a very long area of disease, you have smoking and anal lesions, you might want to swing towards the medical side. Whereas if you have problems that are not going to be solved by medical treatment, you might want a slightly more surgical approach. But I would say if you start to have less than 40 centimeters, start to think about surgery also as a first-line option, at least an option to discuss. And if you start to have longer things and you still feel you need surgery, there are other approaches you can use as well. For example, you can use a long Michelasi strictureplasty over the terminal ileum. I mean, these are great pictures from Andre Dore in Leuven, and I'm very grateful to him for giving them to me. And you can see here you've got a very long strictureplasty over the ileocecal valve, and you've got massive proximal disease segment. And in Andre's data, he will show you that there are a group of patients where the disease actually completely disappears after a few months if you do a colonoscopy. And that's probably related to the fact that you've got quite a wider area and therefore eventually have better disease. But we also have the new things to think about, such as what is the role of the mesentery. And if you look at the surgical approach towards the mesentery, you will see that there are areas where you get a lot of fat trapping and actually get very bulky mesentery, or you might just get bowel type of disease with no real mesenteric involvement. And I think this is where we're going next as well, to see how much of that mesentery needs to come in. I'm not necessarily of the view that you have to remove the mesentery in everyone. I think you've got to actually look at what the mesentery is doing and see what's happening there in terms of whether we remove it. And we've also got other approaches such as the conoes anastomosis, and sadly the founder of this died recently, but certainly the studies that have come through have shown a massively reduced risk of recurrence with this anastomosis. And the principle behind this is that you have, again, a lumen that's away from the mesentery. I'm not entirely sure that that's entirely true, but it certainly has that sort of approach. So, in order to conclude, I would say that surgery now, and with very good training and very good understanding and very good approaches, is actually a very safe way of dealing with limited ileocecal disease, but also other stuff as well. And remember that 42% or so of patients can be medication free, and that's not a bad thing after surgery. So don't neglect the idea that surgery should be brought in terms of your whole um, toolbox and discussion. It's not to say that everyone would agree with it or that everyone is right for it, but it has to be there to discuss. And I think it should certainly be offered as an option because it's a very good option and it has to be done very well by those who do it very well. And I think in some people, it is the best option. So thank you again, and I'm happy to have a chat